The management of early preterm labor threat begins with a comprehensive initial clinical assessment. This assessment includes gathering the patient's medical history, focusing on gestational age, previous preterm birth history, and current symptoms such as contractions, back pain, or vaginal discharge or bleeding. A thorough physical examination follows, which includes checking vital signs, abdominal palpation, and a speculum examination to assess membrane status. Laboratory tests and imaging studies are crucial components of this initial evaluation. These typically include a non-stress test transvaginal ultrasound to measure cervical length, and if necessary, a fetal fibronectin test. Additionally, a complete blood count, C-reactive protein level, and urinalysis with culture are often performed. The management strategy diverges based on gestational age, with a critical threshold at 34 weeks. For pregnancies less than 34 weeks, the approach is more interventional. Hospitalization is usually recommended, along with the administration of corticosteroids to promote fetal lung maturity. The standard regimen is either betamethasone, 12 mg intramuscularly, 2 doses 24 hours apart, or dexamethasone, 6 mg intramuscularly, 4 doses 12 hours apart. Tocolytic therapy is evaluated and may include nifedipine, or, for pregnancies less than 32 weeks, indomethacin, with specific dosing protocols. Magnesium sulfate for fetal neuroprotection is considered for pregnancies less than 32 weeks. Group B streptococcus prophylaxis is administered if indicated. Throughout this period, close maternal and fetal monitoring is essential, and plans for delivery timing and mode are carefully considered. For pregnancies at or beyond 34 weeks, the focus shifts towards preparing for potential delivery. While some cases may still be managed on an outpatient basis, close monitoring is crucial. This includes regular assessments of fetal well-being through NSTs and biophysical profiles. GBS prophylaxis is administered if indicated. The healthcare team evaluates the appropriate mode of delivery, considering both vaginal delivery and cesarean section options. Analgesia and anesthesia assessments are conducted, and consultation with the neonatal unit is arranged. Family information and consent processes are integral parts of this stage. Regardless of gestational age, ongoing follow-up and reevaluation are critical. This includes regular monitoring of contractions, assessment of cervical changes, frequent checks of fetal well-being, and vigilant monitoring for signs of maternal infection. It's important to note that each patient should be evaluated individually, as clinical presentations can vary widely. In cases of clinical suspicion, closer monitoring or early intervention should be considered. The management strategy is critically dependent on both gestational age and fetal condition. A multidisciplinary approach involving obstetricians, neonatologists, and anesthesiologists is often necessary to provide comprehensive care and optimize outcomes for both mother and baby.